السلام عليكم طلبتنا الأعزاء. This will be the first lecture in biochemistry in the renal module. It will be assessment of the glomerular function as a part of the renal function test. In the next lecture, we will discuss the assessment of the tubular function, and then in the subsequent lecture, other topics will be discussed, including the proteinuria, the acid-base balance, sodium and potassium homeostasis, and the renal calculi. The objective of this lecture is to state the biochemical function of the kidney and list the tests that can be used to assess the glomerular function, and we will state the limitation of each of these tests that can be used in the assessment of the glomerular function. The main function of the kidney is urine formation, fluid and electrolyte balance, the regulation of the acid and base balance, in addition to excretion of the waste product of protein metabolism as the urea and creatinine, the excretion of the drug and the toxin from the body, and in addition it have an endocrine role by the production of certain hormone and the response to another hormone and the inactivation of a third category of hormone. It will produce erythropoietin, and erythropoietin is well known for its effect on the production of the RBC. So any patient who have renal impairment will have anemia, may have anemia if there is severe renal impairment, secondary to decrease in the production of erythropoietin. Also, it can produce the 1,25 dihydroxy vitamin D, which is the main or one of the factors that regulate the calcium, phosphorus, and bone metabolism. And any patient who have a defect in the renal system may lead to osteoporosis and abnormality in the calcium and phosphorus metabolism. Also, it will produce renin, and renin is the part of the angiotensin system, and when there is decrease in the blood pressure or decrease in the blood volume, renin will be activated, and renin will activate the angiotensin gene, and then produce angiotensin 1 and 2, and then aldosterone will produce, and it will retain the blood volume and blood pressure to its normal level. All these effects and function of the kidney may be affected if there is impairment in the renal function. So it's important for electrolyte and fluid balance, for blood pressure control by the renin-angiotensin system, important for acid-base balance through the removal of the acid in the urine, and reclamation or regeneration of the bicarbonate. It's important as the route for the excretion of the drug metabolite, and also it will remove the waste product of metabolism, especially the urea creatinine, and it have many endocrine function. The glomeruli is the first part, and it acts of the kidney, and it acts as a sieve or a filter that allow the passage of substance to the tubule, renal tubule. About 200 liters of plasma will enter into the lumen daily, and it contains the same concentration as the concentration of the substance that is found in the circulation, except for minor minor differences. For example, the protein and protein-bound substance, because of their large size, are not allowed to pass by the normal glomeruli, and the small size protein, if they pass, then will be reabsorbed by the tubule. The large volume, which will be about 200 liters of plasma, is very beneficial to our body, because this large amount of fluid, large volume, will allow the elimination of the waste product. Which substance can pass through the glomeruli and which substance cannot pass? This depends on two factors, which are, first of all, the size. Any protein that is, or molecule that is smaller than the size of albumin, can be filtered through the glomeruli. Otherwise, the molecules that are larger cannot pass and return in the circulation. The charge of these molecules are also important, whether it is negative charged or positive charged. If the molecule is positive charged, it can be filtered easily than the negative charge. Why to test renal function, or when to test for renal function? First of all, if we want to see the functional reserve of the kidney, then we will test the renal function. If we suspect that a patient may have certain systemic disease that may affect the kidney function, for example, a diabetic patient may have diabetic nephropathy. So for early detection of this complication, we may examine the kidney function. If a patient already have renal impairment and we want to assess the progress of his disease or the severity of his disease, then we will test his renal function. Other cause of testing renal function is if the patient is already on treatment for certain disease. For example, if he have glomerulonephritis or nephrotic syndrome and he is already on treatment, then we want to see the response to the treatment. We will assess the renal function. The last reason is that some patient is on treatment for other non-renal or maybe even renal disease, and there are on disease that may be nephrotoxic. So we want to measure the effect of the treatment, whether they are affect the kidney or not. So for safe and effective use of drug, any drug that is excreted in the kidney and is taken continuously or in high dose, the renal function must be checked in a regular pattern. Generally, the tests that measure the renal function or assess the renal function can be classified into the tests that measure the glomerular function mainly, and the tests that measure the tubular function mainly. In addition, we have certain marker or analyte that are not exactly part of the renal function, but they are affected by any renal impairment, and their measurement can give an idea about the renal function. For example, the level of protein, the level of albumin, the level of calcium in the blood, the level of phosphorus, and the electrolyte, the sodium and potassium. Also, all these may be affected by renal function. The protein usually is a large molecule, so it cannot pass normally through the healthy glomeruli. If the glomeruli is diseased, then the protein will pass, and this will result in hypoproteinemia and hypoalbuminemia. Also, the calcium and phosphorus may be affected, since the kidney is important as the final site for the hydroxylation of the vitamin D and the production of active vitamin D. So if there is renal impairment, the level of vitamin D will be decreased. So the absorption of calcium and phosphorus may be affected, and the bone metabolism eventually is affected. The level of these element may be affected by renal disease. In addition, urine examination, the urine analysis, general urine exam is also give an important information about the state of the renal function. In this lecture, we will concentrate mainly on the glomerular function. Since the glomeruli is the first part of the nephron, and it acts as a filter or sieve that prevent the passage of certain substance and allow the passage of other material. We can use these criteria to estimate or assess the glomerular function by two main category or two main way. Either we estimate the clearance of volume of blood from certain substance that we choose in a certain period of that time. How can the kidney clear a volume of blood from a certain analyte in a period of time? This is the clearance, and it reflects the glomerular filtration rate. And or the other test, we can measure the blood concentration of certain material that are normally cleared, freely filtered and cleared by the kidney. For example, the plasma level of creatinine and the plasma level of urea. These substances normally are waste product of nitrogen metabolism, and they will be eliminated in the urine normally. If there is damage to the kidney and they cannot be filtered by the glomeruli, their concentration will increase in the circulation. So measurement of these substance can give an idea about the renal impairment. But the renal failure must be advanced with only 20 or 30% of the nephron still functioning before the concentration of urea or creatinine increase in the blood. So it is not very sensitive test of the urine of the renal function. While the first test, which is the clearance, which reflects the glomerular filtration rate, is defined as the volume of plasma from which a measured amount of substance can be completely eliminated into the urine in a unit time. The glomerular filtration rate represents the best indicator of the glomerular function and reflects the number of the functioning nephron. The glomerular filtration rate depends on the net pressure on the membrane, glomerular membrane, and the physical nature of the membrane and the surface area. If a defect occurs in any of these three factors, the net pressure, the physical nature of the membrane, any change in it, or in the surface area, and the surface area will represent the number of the functioning glomeruli. Any change in any of these factors will lead to a deterioration in the renal function, so that the substances that are normally cleared by the kidney, which are the waste product, will accumulate in the plasma instead of being excreted in the urine. For example, the urea and creatinine. So these substances can be measured in the plasma and give an idea about the GFR. So clearance is used as an assessment of the glomerular filtration rate. It is defined as the volume of plasma that can be cleared from a substance in a unit time. So a substance must be measured in both the concentration of substance measured in the plasma and it's measured in the urine. We have certain equation to measure the clearance, which is the urine concentration of a certain substance with a certain criteria multiplied by the volume of the urine per time, and then it will be divided by the plasma concentration of the same material. The result of this equation will be interpreted later on in a specific table, and we will see each number mean what. So, for example, if I depend on the clearance of creatinine, for example, then in this example, I must test the urine concentration of the creatinine and the volume of the urine and then the plasma concentration also of the creatinine, and apply this equation. And for example, if the result is more than 90, it means he have a healthy kidney and the glomerular filtration rate is excellent. This can be used for detecting, for screening the disease, for monitoring the progress, for follow-up of the patient on treatment, and also to guide the dose of the drug to prevent drug toxicity. Can any substance filtered by the kidney used as a marker of the GFR? The answer is no. Not any substance can be used as a marker of GFR. First of all, we must measure, it must be produced as a constant rate. If there is diurnal variation in the substance to be measured, then it will not be a good marker because it will affect the level of the GFR, maybe in the morning differ from the night, and this is not acceptable. And it must be produced endogenously inside the body. It is the better because of easiness of the measurement. In addition, it must be physiologically inert, and it must be freely filtered at the glomerulus. And once it's filtered and passed to the tubule, this substance must not be secreted by the tubule, not reabsorbed by the tubule, not synthesized by the kidney, so that all these factors may affect the concentration of this substance. The substance must not metabolize by the kidney because it may change to metabolite that will decrease the concentration of the main substance. Also, it must not undergo extrarenal elimination. For example, if it is secreted from the kidney and from the intestine, in this case, it does not represent an ideal marker. So, the ideal marker, it means that the amount entering the kidney must exactly equal the amount leaving it. So, it must be freely filtered, must be endogenously produced, must be produced at constant rate. In the tubule, it must not be synthesized or metabolized or secreted or reabsorbed. In addition, there must not be an extra source for elimination other than the kidney. So the clearance, which reflects the glomerular filtration rate, can be measured either by exogenous substance or by endogenous. The example of the exogenous substance that is used, its clearance can be used as a measure of the glomerular filtration rate is the inulin, which is a polysaccharide. This method is the gold standard and the reference method for the assessment of the GFR because it is very accurate, but the defect is that the material used is exogenous. It cannot be produced in our body. It includes the infusion of this exogenous substance at a constant rate inside the circulation, and then at a constant period of time, we will measure the concentration of inulin in the blood and the concentration of inulin in the urine after a certain period of time. And then, according to the concentration, we will calculate the rate of the clearance of this substance. Although it is a reference method and it is very accurate, but the defect is that it is an inconvenient method because it is exogenous and need to be continuously infused, and there is repeated measurement of the blood sampling of the for the measurement of its concentration in the blood and urine. So because of this, then this method, although it is accurate, there will be encouragement of the use of endogenous substance. The most popular one that is used to measure the endogenous, the GFR, is the creatinine. Creatinine is an endogenous material inside our body, and it is the end product of nitrogen metabolism, and it is synthesized in many organs in the body, for example, in the liver, in the pancreas, and in the kidney. And after it is synthesized in these organs, it will be transported to other sites, for example, mainly the muscle and the brain. The creatine, by losing water non-enzymatically, it will be converted to another compound. It is called creatinine. Why we choose creatinine as a measure of the GFR? Because when it's filtered by the kidney, it's freely filtered, it will go no more metabolism, and then is secreted in the kidney, in the urine, and freely filtered at the glomerulus. So we can measure its concentration in the blood and its concentration in the urine and the volume of the urine, and then we apply the equation that is mentioned in the previous slides, and then the GFR can be calculated. So till now we determine two substances that can be used as a measure of the GFR. The first one is the exogenous substance, which is the inulin, and the second one is endogenous, which is the creatinine. This equation can be applied. The creatinine clearance is determined by the urine concentration of the creatinine multiplied by the volume per time, how many ml per minute within a specified time, and then they will divide them by the plasma concentration of the creatinine, and the result will be the clearance of creatinine. How much of the creatinine can be cleared from the kidney in a unit time? This is the clearance, and the clearance reflect the glomerular filtration rate. And the glomerular filtration rate is the best indicator of the glomerular function and reflect the number of functioning glomeruli. So, if we calculate the clearance of whatever endogenous or exogenous substance, and the GFR was greater than 90 ml per minute per 1.73 squared meter, then we considered that the glomerular filtration rate according to the clearance is normal. And if the GFR or the clearance was between 60 and 89, then it indicates that the patient have an early renal insufficiency, and other marker may be elevated in this stage. He may have plasma urine start to increase, the plasma creatinine also started to increase, the parathyroid hormone increase at this stage. Stage 3 can be divided into two parts, either 3A and 3B, depending on the clearance. If the GFR was between 45 to 559, then it is 3.8, and if it was between 30 to 44 ml per minute per 1.73 squared meter, then in both of these, this is stage 3B, and both stage 3A and B considered to be chronic renal failure. So 3A, or generally 3, is chronic renal failure, and at this stage the calcium absorption also will be affected. It will decrease. Lipoprotein lipase activity decrease. There will be malnutrition, anemia. The anemia will be because the erythropoietin concentration will be decreased because there is damage to the cell that produce erythropoietin that is found in the kidney, and we know that the erythropoietin is the stimulator for the RBC production. Then the more severe stage, when the GFR was between 15 to 29 ml per minute per 1.73 squared meter, this indicates severe renal failure. The patient may also complain at this stage of hypertriglyceridemia, hyperphosphatemia, and metabolic acidosis with hyperkalemia. And if the patient, the clearance and the GFR was less than 15 ml per minute per 1.73 squared meter, this patient have end-stage renal disease, and there will be a very marked elevation of the plasma concentration of both the urea and creatinine. So when we measure the clearance, and the clearance reflect the glomerular filtration rate, depending on the marker, whether exogenous or the endogenous marker. The exogenous is the inulin and the endogenous is the creatinine, which is the most commonly used marker. The result, and after we measure their concentration in the plasma and in the urine and the volume of the urine, we apply the previous equation. Then the result of the equation, we found the patient whether, according to the result of the equation, we will find whether whether it's more than 90 and it is normal, or maybe anywhere in this stage, and accordingly we can classify the stage of the renal impairment of this patient. The GFR that can be calculated from the previous slides was the measured GFR, or the measured glomerular filtration rate. Why measured? Because it depends on the measurement of the creatinine, for example, in both the plasma and the urine. Nowadays, many equations can can estimate the glomerular filtration rate depending on estimation and measurement of the plasma creatinine without the need for measurement of its concentration in the urine. They found that this way may be better because maybe measurement of plasma and urine concentration may both be more difficult than measurement of plasma creatinine alone, and because creatinine is found mainly in the muscle and reflect the muscle mass and depend on many factors, the age, the gender, and the weight all affect the creatinine level. So they create a certain equation, and many equations in fact, and this equation will estimate the GFR and correct for the factor. For example, this is the Cockcroft and Colt equation. This equation, they estimate the clearance if they apply this one, 140 minus the age in years multiplied by the weight in kg, and all will be divided by 72 multiplied by the serum creatinine or plasma creatinine. In this case, we only single measurement of creatinine can be applied, and if the patient was female, then also we calculate the weight will be multiplied by the 0.85 to correct for the gender effect, because creatinine is derived from the muscle, and the muscle mass is less in the female, so it will correct for the weight, correct for the age, and correct for the gender. If the female, then we multiply it by a factor. Other equation that's popular is called the MDRD. This is the GFR. It's below 15, it is kidney failure. Between 50 to 60, there will be kidney disease. More than 90, it is normal. 30 to 60 is early impairment. Creatinine also, as a plasma concentration without application of the clearance, can also give an idea about the state of the glomerular function by measurement of the plasma creatinine level. Sometimes we found that the plasma creatinine is more than the upper normal reference range. In this condition, there may be, it's either due to renal disease, for example, acute renal damage or chronic renal damage, may lead to a pathological increase in the plasma creatinine. Why we depend on creatinine? Because it's freely filtered, it's a waste product and the end product of nitrogen metabolism. So it's a waste that is normally filtered freely at the kidney, and then it will be excreted in the urine. So if there is any defect in the glomerular filtration, in this case, the concentration cannot be filtered, so the concentration will increase in the circulation. Sometimes it's elevated without indicate that there is renal impairment. For example, after taking a high meat meal, if there is heavy exercise, because it will be liberated from the muscle, or some drug also will increase the level of creatinine. For example, the aspirin, the thiosulate may increase the level. This is the non-pathological or transient effect that lead to increase the creatinine, but mainly if it is persistent and high, we will think of renal cause. Sometimes it will be reduced, maybe due to pregnancy. It is a physiological cause, and this may be due to a delusional effect. And sometimes there will be pathological decrease in the creatinine when the muscle mass in anybody is low, maybe due to wasting disease, due to steroid therapy that will also lead to muscle wasting, or when there is starvation. Then in this condition, there will be a decrease in the plasma creatinine level. So creatinine is a marker that can be used to assess the glomerular function in case when the plasma level is increased. The other marker that can be used to assess the glomerular level is the plasma cystatin concentration. We take a blood sample and we measure the level of cystatin. It is better than creatinine because it is not affected by age. It is not affected by the muscle. Creatinine is derived from the muscle, so the muscle mass will affect the level of creatinine, while cystatin C is not affected by the level of the muscle mass. In addition, cystatin C is not affected by a diet that is rich in meat. It will increase the level of creatinine, but it will not affect the level of cystatin C. So it is more reliable than creatinine. It is freely filtered by the glomerulus. It is not returned to the blood circulation after filtration, and if there is damage to the kidney, then the concentration and when there is damage to the kidney and there is decrease in the GFR, as we mentioned in the previous table, when we see that when we compare the plasma creatinine and the plasma cystatin level, we will find that the plasma cystatin C level will increase sooner than creatinine concentration, and is very useful. It can give it means that it is a sensitive marker. Early damage lead to increase in the cystatin C. It is very good marker. Sometimes the drawback of cystatin C is that it is reabsorbed and metabolized by the renal tubule, and not secreted by the tubule. This is the difference between it and cystatin. So it is more sensitive than creatinine, not affected by the muscle mass, not affected by the age of the patient, not affected by the diet, and increase more rapidly than the increase in the creatinine when there is a decrease in the GFR. What is cystatin C? It's a low molecular weight protein, acts as a protease inhibitor, and it is formed at a constant rate. So it is this criteria make it a good marker for glomerular function. It is freely filtered by the glomerulus. This is the second criteria that fit the ideal criteria. And clearance is from glomerular filtration only. It means that there is no extrarenal way of clearance, and this is another good criteria for cystatin C. And we can also measure it and incorporate it in the equation for the estimated GFR equation. We say that the estimated means equation for measurement of GFR depend on the measurement of plasma level of this marker, either cystatin or creatinine. The other marker that's used for assessing the glomerular function, this is the plasma urea concentration, although it is of a limited value for assessing the glomerular function because it's affected by many non-renal causes. This urea is formed from the ammonia. It is formed in the liver in the urea cycle. When there is deamination of the amino acid, it will be converted to ammonia, and ammonia in the liver in the urea cycle will be converted to urea, and the urea will be excreted in the kidney, and a small amount will be lost in the skin and the GIT tract, and this will add inaccuracy for its measurement. So it is not eliminated by renal route only. It have an extra-renal route for elimination, and in addition, it's highly affected by a protein diet. Any protein diet may lead to increase in the plasma urea concentration. Even more, the effect is more on urea than on creatinine level. Any increase in protein catabolism will lead to increase in the urea concentration after trauma, after major surgery, and bleeding in the GIT also will increase the blood urea level. So all these will add to the inaccuracy of plasma urea concentration as a measure of glomerular function. In addition, urea is affected by the dehydration level. Dehydration lead to increase in the plasma urea level. So all these make the measurement of plasma urea concentration as a marker of glomerular function inferior to plasma creatinine. For all these reasons, the clearance, if it's measured by urea, does not reflect the glomerular filtration rate very accurately.